Welcome everyone to the CTSNet webinar on the guest editor series, Connecting Patients, Clinicians, and Outstanding Cardiac Care Through Nursing and Allied Professional Research, curated by co-guest editors Jill Lay and Tara Bartley. Thank you for joining us. Please note this webinar is being recorded and will be available this Wednesday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce CTSNet co-guest editors and moderators of this webinar, Jill Lay and Tara Bartley. Jill Lay is a clinical nurse specialist, researcher, mentor, and educator of multidisciplinary providers nationwide, as well as a longtime CTSNet associate editor. She has many publications and presentations to her credit and was inducted as a fellow in the American Academy of Nursing in recognition for her lifelong professional contributions, particularly her work in establishing cardiac surgical resuscitation standards of care. Tara has nursed for 40 years in surgery, medicine, and emergency care, specializing in critical care, cardiothoracic, and transplantation nursing. She qualified as an advanced practitioner in 2004 and a non-medical prescriber in 2008. She currently works as lead advanced cardiothoracic clinical practitioner at the Queen Elizabeth Hospital, Birmingham and corporate lead ACP, University Hospitals Sussex. Tara was awarded a fellowship of the Royal College of Nursing, UK in 2011 and made an officer of the Order of the British Empire in 2014. Welcome, Jill and Tara. I'll turn it over to you.
Thank you very much. I'm delighted to be here today to kick off this exciting series. CTSNet Guest Editor Series webinar today will feature nursing and allied professional research topics of interest to the CTSNet membership and beyond. I'm incredibly excited about these presentations and partnering with the Connect group, which you'll hear much more about today from these outstanding authors. I'd like to first introduce my co-editor for the series, Tara Bartley, a cardiothoracic clinical practitioner renowned for her leadership in the UK and Europe. We've had the opportunity to work together on many projects and presentations for the cardiothoracic societies, and I'm incredibly pleased to be working with her here today. Tara, would you please say a few words and start our speakers?
Jill, thank you very much. Good afternoon or good morning and welcome to everybody from across all the different continents that are joining us. This is truly a very exciting series that Jill and I are being able to offer and share with yourselves. We are particularly grateful today to all the members of Connect, particularly Julie, who I've worked with in the UK on a number of different projects as well. And the disparate nature of the presentations that we have been able to acquire for this particular episode of the series are very invigorating and quite diverse, but they also have some really good common themes that the nursing and the allied health professional group that work together are across all the different countries and nations are key to making us better practitioners, but more importantly, what that actually does for our patients. And what we're hoping today is to bring a very practical approach based upon sort of that transcending research, which is always quite difficult for us to undertake with all the issues that we have around clinical demands and other demands in our lives, and show that what the impact that can have really on patients. And so we're hoping that the discussion will sort of bring together the common themes of those challenges for ourselves and what it means to patients, what it means to care, and how we can share our learning. So the first video that we were able to sort of put up was from Stacey Matthews, who is unable to join us today, but Stacey works in Melbourne. She's got a Bachelor of Nursing and postgraduate qualifications and is a clinical nurse specialist, but is also a senior nurse advisor to the National Heart Fund in Australia. And the key theme to what Stacey was able to share with us was around the challenges of gender and how does gender influence the work that we undertake. And more specifically, it demonstrated that we had 1 in 4 percentage of mortality of women, of all female deaths. And it talked about gender issues, the menopause, the difference in sort of the surgical approach. And so I suppose in absence of Stacey, I'm going to invite Julie to sort of talk to us about the challenges around where we are with women in research and where we would like to go and where we would like to be, really. Julie, may I invite Julie Saunders? And Julie, I'm going to ask you to introduce yourself, please, as our well-known professor in the UK.
Thank you, Tara, and good morning or afternoon, wherever you may be listening to this webinar. So I'm Julie Saunders. I'm Director of Clinical Research, leading on nursing and allied professional research at St Bartholomew's Hospital in London, UK, and Clinical Professor of Cardiovascular Nursing. And all of my background's in really in cardiac surgery, outcomes and care. And one of the particular interests that's kind of emerged quite recently and has given me the opportunity to collaborate with Stacey and with Rochelle is looking at some of the sex-specific differences, particularly in outcomes. And I think there are a few, just to summarise a few key points, is that one of the things is that women are underrepresented at each stage of the pathway. And that's through from diagnosis to referral to then to surgery, and then also have potentially poorer outcomes. And that's often because by the time they get to surgery, they're older, and have more comorbidities in a nutshell. And there's lots of reasons, as Stacey goes in her video, as to why that may be. But one of the other factors that Connect is particularly interested in, and we will be looking at more as we go forwards, is the underrepresentation of women in research studies that enable better care of women at each stage of the pathway. And so we know that women are particularly underrepresented in all forms of cardiovascular trials, not just in cardiac surgery trials. And some of that is because they're excluded because of their age range and maybe of childbearing age, or trials often exclude people through the menopause, or particularly older women as well, and often those with comorbidities, and often for drug trials in particular, a loss of comorbidities or a particular range of comorbidities are often excluded. But there are some really practical things as well. So things like how patients are recruited into studies and the opportunities we give them to take part in research. And that can be from, as I've already explained, about exclusion criteria, but it can also be about whether we make the research environment friendly and nice enough and practical enough for them to be able to agree to take part, but then be able to continue through the whole study. And those are things like travel expenses, fitting in with childcare, whether it be your own children or grandchildren, other caring responsibilities, etc. So there's a lot of avenues to kind of explore for women in cardiovascular care, and particularly after cardiac surgery. And I think one of the key things is that we need more research specifically in women, and using the techniques that we can to recruit and then retain them in clinical trials to get that evidence base. You're on mute, Tara.
Rookie error straight away, failed on the mute. Julie, thank you very much, and thank you for that prompt. I would just like to encourage our participants that have joined us today to use the question and answer function rather than the chat function, although we will pick up if there are any issues in the chat, to pose any questions to our panel today. And just picking up where Julie was mentioning there, you know, it's narrowing now, isn't it, in terms of life expectancy from men and women, and we mustn't exclude our, you know, the rest of the population of people who, you know, maybe change their gender or whatever. But I think, you know, the points that you raise about comorbidities, and yet life expectancy for women has traditionally been longer, definitely underpins exactly what you're saying, really. And I think is it maybe, you know, pertinent to think, is that echoed in the fact that, you know, predominantly nursing is female orientated, although that could be questioned, but our cardiac surgical colleagues from medicine and surgical side of things is predominantly has been predominantly men, albeit that in the UK, the number of people coming into medicine and surgery as trainee doctors is at least 50% balanced now. But going into cardiac surgery specifically, you know, we are a long way off having an equity of gender provision, really. So it sort of takes me on, if we will, unless anyone's got any questions. I've just say to Hannah or Jill, is there anything anyone would like to add in comment to Julie's, or shall we try and bring, you know, our other colleagues in terms of discussing aspects? Jill, just a comment from you, please.
I think the one thing that, you know, really I was struck by was we did research years ago looking at octogenarians having cardiac surgery. And what I was struck by at the time was the majority of the women in that group were having valve surgery, and the majority of males in that group were having coronary bypass surgery. And we had very few females in their 80s undergoing coronary bypass grafting. So I think they really are very different populations with very different comorbid conditions, and to lump them all in is going to do both populations a disservice. So I really appreciate teasing out these gender differences. Julie, would you care to comment just a bit more?
So I was just going to make a comment, if I may, on what Tara's last comment, which was about the distribution of female researchers and clinicians. And I think there's definitely evidence, particularly in cardiovascular, that there aren't enough women on editorial boards, there aren't enough women doing research and coming through, whether they be nurses or whether they be doctors either. So I think one of the key things that Connect has as part of our aims is very much about increasing the nursing and allied profession research leaders of the future. And as you say, typically there are proportionately more women in nursing and allied professions. So hopefully we'll be able to start slowly addressing getting more females undertaking research, which so far, both in clinical trials, grants and editorial boards are not quite there yet.
Thank you, Julie. I saw Rochelle nodding as well earlier on when that, and some of you may have noticed that I just phased out slightly there. I lost my connection, but I've rejoined us just as Jill was finishing chatting. So I can't see anything in the Q&A at the moment, or the chat. So shall we move to sort of introduce the next video that we have, which is by our colleague Carrie. So Carrie is in Norway, and is part of a public health and nursing faculty of medicine, and her particular paper was looking at pain and perceptions of pain, and I think was particularly important in looking at the patient voice, wasn't it, Carrie, and bringing out whether, you know, everything that we do, taking what we've already talked about from a theme of sort of, you know, research and what's important, but actually, you know, I've just been a patient myself, and I tell you what has been important was the way people spoke to me, whether they introduced themselves, and whether I actually, for want of a better term, had a voice, whether I was heard. And it sort of segues very nicely in what the work that Carrie has done in terms of the sort of looking at the acute and the chronic and the voice of the patient into the sort of the PROM side of things for one of our other presentations today. So Carrie, do you want to just give us your thoughts on how we make sure that we give, it's on twofold, isn't it, really? We give the patient the opportunity to say what they want, but we also, as practitioners, give them the professional courtesy that we actually hear what they say, and it's not just sort of I suppose, you know, something that we feel like we're doing but then we don't action. Thank you.
Thank you for your introduction, Tara, and thank you as well for bringing up this important question, because that's my point exactly, that we have to ask the patients themselves about their pain and how they rate their pain and how they cope with their pain. And I think it's important to be sure for a patient that it's not considered a complaint, because I think many patients think they should not complain. They are grateful, undergoing and surviving cardiac surgery. But we need to assure that we really, really want to hear their voice, to better care for the individual patient, but also to improve the care in a more generic way.
Yeah, I mean, I think that's absolutely fundamental, isn't it? Because are we just playing lip service to what they say, or are we really listening to them? And if we are allowing them to speak and be heard, is there an anxiety from their point of view that it will affect their care? So that whole concept of being not dissatisfied with what we're doing, but us not meeting their needs is about, one of the sentences I often use for patients is, nobody knows your body better than you do. I can only surmise what you're going through. Please tell me if I'm right or wrong. And moving sort of into that whole different juncture of whether we say the right words, we hear the right words, but also does our body language express that we really do want to hear what they're saying, and that we do, we do recognize them as people in their own right. It's amazing when you walk into a patient's room and you look at what's on the bed table and the book or whatever, and you start a conversation that shows you are really interested in them as an individual, isn't it? And those are the things I think that people take with them as their memory when they leave hospital. Can I ask if anyone else has any thoughts? And Jill, if you want to come in at all?
Yeah, I did want to go ahead and just re-emphasize what you said. Personally, my sister just went through a cancer treatment, and she said those very words to me. I don't want to say that I'm in pain. I don't want to be a bad patient. And I was really struck by those words. She's an intelligent woman. And so, what can we do? Is it just a matter of giving permission? Is there anything else we can do besides our approach and our queries to make patients feel more comfortable having these conversations and letting us know how we can meet their needs without making them feel guilty?
And it takes us, doesn't it, right back into, what Julie was just saying about having research, having the profile of women in research at a higher level so that their voice is heard through a legitimate way that gets published and gets shared and recognized by others, as well as that sort of one-to-one or, very sort of individual side of things for patients on a one-on-one. So,
I was also wondering about gender differences in pain. It was my own perception that when I was discharging, females, they needed to go home and take care of the house and were less interested in taking pain medicine because they had things to do. Have studies borne those differences out in any way?
I was just going to invite Carrie to comment. Sorry.
Okay, sorry. Well, there are studies of women and pain in general, of course, and women have more pain than men in general, but also studies on cardiac surgery, and they have the same findings, that women have other responsibilities, which may be a barrier against taking their pain medication, but also coping with their pain. And I think that the subacute pain is very important and underestimated, because when the patients, women and men, go home, they have to adhere to the pain medication and also other interventions, but often they don't, because they don't have the information of how important it is. And one study by my Norwegian colleague Irene Lie showed that women waited until the pain was unbearable, then they took their paracetamol when they got home, instead of doing it regularly as they were instructed to.
I mean, I'm mindful I don't want to alienate any of our sort of, non-gender specific or male people that are on the audience and their contribution as well, because we do know it is very individualized. So we do need to recognize that, there are households where, male, female, gender traditional roles are no longer, and we're moving towards that as well. So please don't let us feel that we're alienating any of our audience or audiences for the future, and bear in mind, you know, that we are becoming a sort of, you know, our pronouns are changing, and, you know, we should be respectful of everybody, of where they're coming from and what they're doing. But I think at the moment, the research side of things is definitely going to be looking at the legacy of how, you know, over the generations things have been, and the responsibilities that people have had in their lives. So, but it's important, isn't it, really? I think the key theme here is whoever you are, that you are allowed to speak. You have, I suppose, a given permission to speak, but you also, your voice is heard, isn't it, really? And that everything we say when we invite comment, like Jill said, for a family member is in our body language as well as what we articulate. Can I ask if any of the audience have any Q&As? Just a reminder, just to pop them on the Q&A section, and if you're struggling to do that, the chat. Is there anyone else on the panel that has anything further that they would like to add on that subject? Okay, so what we'll do now is I'm going to introduce my colleague Rosalind. Rosalind works at Bart's Hospital in London, so we have met face to face on a number of occasions, so welcome. You're doing sort of the work that you're sharing with us in your role sort of at the moment as your clinical director research fellow, is that not correct? And you're in your PhD, although perhaps you would just like to give us a little bit more information about that and how far through you are, and sharing with us sort of your work on surgical site infections in terms of the focus of the assessment, the presentation and the management. And I think it raises some really pertinent sort of points that, you know, we're here to do good. We don't want to do any harm to our patients, but it is such that, you know, we will have a number of our patients present with SSIs, and depending on you know, when they're picked up and the management, etc., that you're talking about, we'll look at how they are, you know, whether they're sort of entrenched SSIs that have a huge economic and patient impact, or whether or not we can focus our energies on identifying them early. So Rosalind, welcome.
Thank you, Tara, and welcome. Thank you for inviting us for this webinar as well. It's been a pleasure to be joining you today. So as you have said, I'm a PhD student at Queen Mary University of London, and although my PhD study is on aortovascular surgery, I have a special interest in surgical site infection. So I have developed the BART surgical infection risk tool that we are currently using at BART's as part of my master's dissertation. And as you have said, I mean, in the video, we have discussed obviously the management, the definition of SSI, the management of SSI, and the prevention of SSI, and we have emphasize the huge variation in the practices from the diagnosis, prevention, and treatment of surgical site infection in cardiac surgery in particular. So we are currently doing a lot of work in hopefully standardizing the practice, and this is part of the work of the Cardiac Interdisciplinary Research Network, which is a network of medical nursing and allied professionals who are interested in research in cardiac and thoracic surgery. So the main project, target wound infection, is a response to the national survey that we've conducted that shows a significant variations, as I've said, in the diagnosis, prevention, and treatment of surgical site infection. So it is an NIHR-funded study which ultimately aimed to develop a nationally validated risk score calculated from nationally collected data we are also identifying the barriers and facilitators in the SSI prevention practices, and hopefully we'll be able to develop a national standardized surveillance strategy. And through this work, we are hoping to help, standardize the definition of surgical site infection across the UK, and hopefully across the globe as well, and develop a standardized prevention, treatment, and surveillance strategy nationally, and potentially develop an international randomized control trial related to these topics.
Thank you. I mean, it's such a complex issue, isn't it? Both in
It is.
terms of the subjective nature of assessing a wound,
Correct.
and the challenge that you have to put it into objective measures. And then when you think of everything that contributes towards an SSI, in terms of patient compliance, the environment, from everything from whether you've got, aircon that's working properly, how much bed space you've got to be able to look at wounds and dress wounds, have you got the right equipment? And because we're here today talking across many countries, then inevitably that benchmark baseline will be different, won't it, for lots of people? And so it's a huge credit to yourself in terms of looking at the mortality rate for patients, which sort of, I think you quoted, correct me if I'm wrong, was about 1.6, and the whole issue around not only the mortality but the morbidity of the impact of SSI along the lines of both for patients, for the human resources in their healthcare systems, and then the economic and financial resources as well, at a time when we can be more stretched, really. Jill, I think you had a question that you were going to ask.
Yeah, I was really interested in basically, as you said, there's so many variables. Is there one thing that we could be focusing on? Where do you think that we could make the most impact at this point in time? I mean, from a risk assessment, there's not much I can do if my patient is a diabetic. What can I do as a provider other than being aware of those risk factors to alter their course of an infection risk?
Yes, that's a very good question, Jill, and thank you for asking that, because we have just recently finished identifying the barriers in the SSI prevention practices, and we're hopefully publishing the paper very, very soon. But I think one of the most important, and without telling you the whole result of the study, one of the most important factors that we have identified that we can definitely act on now is maintaining the traffic in theater. And this is the same problem across the centers that we have looked at. And just, I don't know in your cardiac center, but particularly, for example, from our own experience, the number of people getting in and out of a specific theater during the cardiac operation is massive, and we're thinking that could potentially, obviously, increase the incidence of surgical site infection. Obviously, we don't know because we don't have an RCT yet to confirm that, but that could be a potential reason why we have an increased SSI as well. So if we can maintain, the traffic, maintaining the lowest number of people and only the most important people coming in, and when I mean important people, it will just be the surgeon, the anesthetists, and the scrub nurses and the circulating nurses working for that particular patients, rather than other staff moving from one theater to another.
Thank you. There's a question in the chat actually from Maria Hayes. Thank you, great discussion, and thank you for that. What are your thoughts on negative pressure dressings at the time of surgery and its impact on reducing SSI rates? So Maria shares with us that they've seen a big reduction in their center.
Yes, so thank you. That's another very good question. Thank you for that, Maria. So, well, there is actually no RCT to say what, particularly in cardiac surgery, the effectiveness of negative pressure. However, from the NICE guideline, which is the national guidelines in the UK, they have recommended its use, and that's why many of the cardiac centers utilize it in across the country. I mean, in the UK. However, again, it's quite difficult because the recommendation from the WHO and the NICE guidelines was for high-risk patient, but there is no standardized risk assessment tool to say or to identify who are the high-risk patients. So I think that's another thing that we need to look at once we've established the standardized risk assessment tool nationally. And that's the reason why that's the first thing that we are focusing with the target wound infection, because that's going to be the basis, hopefully, of all the other interventions that we're going to be developing in the end, or evaluating the interventions that we are actually doing at the moment clinically.
That's really, really significant. Thank you for raising that, Maria, mainly because if you want to start to change a practice and use, something like that, then there is that economic financial discussion that you will have with the people that will be paying the bill. And you need to be able to have, your data to be able to quote to them. So thank you.
Absolutely.
In the essence of time, I would like to hand over to Jill to discuss and lead the discussion on our next 3 papers. Jill, thank you.
Thank you so much, Tara. I am delighted to introduce the content for our next subject. Professor Rochelle Wynne is a clinical nurse consultant in the Department of Cardiothoracic at the Royal Melbourne Hospital in Australia. And she's shared some wonderful perspectives on patient perspectives and what really matters to them. I was very interested in your presentation and really moving beyond patient satisfaction, which to me often feels like a customer service check-in, as opposed to really what patients want us to do to help them recover. So could you just help us, start with, your key thoughts about how we can do a better job of listening to what our patients are telling us on a standardized level?
Sure. Many thanks for the introduction, Jill, and the opportunity to be here today, Jill and Tara. It's fantastic. Look, I think as I alluded to in the video, we have this range of patient-reported outcome measures, and they're often traditionally disease-specific, and they've been developed from the perspective of clinical researchers or academic researchers postulating what is best to capture. And traditionally, there has been very little patient involvement in articulating and testing those sorts of tools. So while satisfaction seems a fairly straightforward concept, the other sorts of patient-reported outcome measures like health-related quality of life and functional status and frailty, symptoms and symptom burden, and there's also a range of measures focused on health behaviours and patient experience more broadly. They tend to have been developed with a purpose, and that purpose hasn't always been informed by patient perspectives. So I think if we want to move beyond that, we have to, first of all, have patients involved in the conversation and the development of instruments. And I think we have to start thinking a little bit more laterally about what it is that will help patients to engage in their preparation for surgery and their recovery. We don't really know, and this crosses a few of the topics that we covered tonight. There's a body of evidence available, but that evidence isn't always informed by patients' perspectives, and that then makes you question the relevance of it. I mean, we have this whole gender debate around sex-specific differences, and we know that the disproportionate representation of women then renders a whole lot of things that have been tested in cardiac surgical populations quite highly likely to be ineffective for women because they haven't really been tested on women in those trials. So it's if we're thinking about patient-reported outcome measures, it's not dissimilar in that we have to think about making sure we've got the right proportion of patients from a gender and race, ethnicity perspective, and receiving input from all of the various types of patients that we look after and try to improve, getting their perspectives on what it is that they think is important in their recovery and preparation, and developing goal-oriented outcomes that can give us optimal insight into things that will make a difference in terms of patient engagement and motivation, and having patients really own their recovery to some extent. So I think we have to start moving beyond satisfaction and get a little bit more complicated, but also a little bit more lateral in our thinking, and try and move beyond the traditional perspectives into the future.
Thank you. I really appreciated your perspective, and I thought it was quite thought-provoking. And I definitely want to make sure we get more time for your discussion. But in the interest of time, I want to make sure I do get a chance to introduce both Suzanne and Julie, and then we'll have time for Q&A. So again, for the audience, if you've got questions for any of our panelists, if you'll just put them in the Q&A box, we'll be able to read through them, and we'll come up to more questions, particularly from the audience here in just a little bit. But thank you so much. I really appreciate that perspective. Our next presenter is Suzanne Frederick. She's a nurse researcher from Toronto, Canada, and she's really done a wonderful job of talking to us about professional practice models and how we might include research participation at the bedside. In particular, she cited a study that looked at an 80-20 professional practice model where 80% of clinical time was spent at the bedside and 20% was devoted to research activities, and reported metrics of improved productivity, improved staff and patient satisfaction. And so my question for Suzanne is, this is wonderful research. I'd like to hear more about how we can get research activity at the bedside happening. Are there any studies that have documented clinical improvements in patient outcomes based on these professional practice models? Anything else we can do to encourage this type of activity at the bedside on a more broad scale?
Thank you, and thank you very much, CTSNet, for inviting Connect to collaborate on this webinar. Great question, Jill. Thank you very much. Actually, for the study that I cited, it was just staff-reported outcomes in which data was collected and presented. Pre-COVID, the study team had started to collect data on patient outcomes. That study paused for a period of 3 years, and it is just about to resume again. So currently, the answer to your initial question is no. There is no patient outcomes as of yet reported. Yes, indeed, we do need more work in this area. And in terms of suggestions for moving forward, I think right at the outset, there needs to be a significant change in organizational culture and the desire, because if you don't have from the top right down, the desire to want to engage in and to have your nurses, allied professionals engaged in research at the bedside, it's not going to happen directly at the bedside. You do need that support right at the top. So there does need to be a change in organizational culture. And I foresee it being a lot easier because there tends to be a greater uptake in teaching hospitals. So in a North American perspective, we have a lot of teaching academic-based hospitals, and we also have community hospitals. It's a lot easier in teaching hospitals, mainly because they already have that research infrastructure in place. There is a significant amount of funding already has been acquired, but it's I think just a change in in recognition that we do need to transition into having other healthcare providers engage in the generation of knowledge at the bedside, and that's really what's needed. There and ways in which we can do this is potentially having some sort of, there is a need for increased awareness, increased advertising, communication, marketing of the benefits of nurses and allied professionals engaging in research directly at the bedside, and maybe in lack of understanding or awareness that yes, other professions can engage in this, and what are the benefits of having our colleagues across the spectrum engaging in the generation of evidence, and just making that more readily available to everyone as well. Sorry.
I was just you made one really important comment, and that was that there's such a broad perspective of negativity around research by staff. And I heard that before, unfortunately, too many times. So I think, you talk about culture and the negativity. I think to me, that seems like a great place to start, is just, talking to people about what interests them. What are your thoughts about how to change that culture, initial steps that might be taken?
Right. And so one of the big things is right now, I know our professional associations for within nursing itself is moving towards engaging in just that, engaging in the marketing, having conversations with the CEOs of organizations, and looking to see if there's opportunities for collaboration, and running smaller pilot projects across specific units. So not having everything done all at once, but testing out different areas. And so there is that conversation that's happening, again, within the teaching hospitals, but it's being led by our nursing professional associations. Again, we do need to extend that across the allied professions as well, to so that we can all mimic and engage in the same type of uniform activity. There should also be a consideration in terms of looking at integrated funding models, for example, and thinking about ways in which when we're looking at acquiring funding, for example, there be some dedication of that funding be positioned towards supporting environments where there is the buyout of time for staff to be able to engage in research. Looking at collaboration with specifically industry sponsors, or even partners such as ESC or other larger associations, where there can be that support and mentorship, and even to a certain extent potentially buyout and funding for the buyout of time, because that's one of the things with the 80-20 model they had suggested is the biggest challenge here is you do need that time buyout, the funding for it, to have someone cover your time for you to spend the, say, 10 hours a week, for example, in engaging in research, because you need to move away from the patient setting in order to engage in the research work. And that research work doesn't have to be generation of creation of new knowledge. It could be, for example, looking at learning how to read evidence, learning how to critique evidence. So when we talk about research, and when Ferguson and Paré talk about research, they talk about it not just you being a lead investigator. It's about how do you use that evidence in practice to inform your practice, and just acquiring those skills, moving beyond what you're learning in the nursing curriculum, for example, in undergraduate, and then being able to apply that in the practice setting, because that transition is also lost. And so they also suggested in terms of mentorship, looking at, for example, nurse practitioners or masters or advanced practice RNs and nurse and allied professionals supporting our junior colleagues in terms of the engagement in research. Just a few broad ideas in a short time that we have to discuss.
Can I just jump in, Jill? Sorry, just homing in there on that whole concept. It's about leadership, and our colleagues, our medical colleagues, have what we call in the UK job plans, which work out exactly, you know, their non-clinical duties, etc. And so we're moving towards that in nursing and allied health professionals in the UK, particularly under the auspices of advanced practice, where all new jobs have to have, you know, sort of hopefully a balance between those. And so what we have is you know, when I accept people for academic study and go towards helping them, you know, it's a conversation with their line managers, etc., to make sure that the job plan reflects that time to do it. So it's just to underpin what you said. So sorry to jump in, Jill. Jill, you're on mute.
Thank you. No, that was very helpful. And I do find, you know, that what I found is we'd have dedicated time cut away for projects, and then somehow things get busy and staff get pulled away from those and get put back into the count, if you will. So protecting that time sounds wonderful, but unfortunately can be a real challenge. Before I move on to Julie, any other questions for Rochelle or Suzanne? I think, you know, I didn't mean to give you short shift. We really appreciate all of the content that's been presented here today. Any other questions for those panelists?
So there's nothing else in the Q&A or the chat as it stands at the moment, but we would encourage people by all means to make use of that facility.
Good. Well, then let me just go ahead and make sure that I get Julie introduced properly here. She's already introduced herself. She has, you know, really represented Connect in this video and at other forums. And I just found it to be a wonderful organization, was really excited to partner with CTSNet and Connect so that we could hear all the great work that they're doing. So I've really appreciated hearing these researchers. And Julie, my question for you is there any other research that your team is working on that you feel like, you know, we should have had here, we just didn't have enough time for it? And then later we'll ask CTSNet to provide information to all of the panelists and audience about how they might be able to submit videos or other content to CTSNet in the future with great information like we've heard today.
Thank you, Jill. Yes, I mean, Connect has really grown over the last kind of couple of years since we first launched, and we have members across the globe, and we're growing all the time, which is very nice to see. And of course, we have a lot of topics that people are working on and have vast clinical and research expertise in. So today, the showcases or the video showcase a handful of those kind of areas, but we have people looking at frailty, delirium, cognitive function, psychosocial outcomes, recovery in ICU, so ICU acquired weakness, so that initial recovery in the intensive care unit. We also have members that are looking at how to describe cardiovascular disease from the patient perspectives through art. So we have a wide range of topics, but being methods of research. And of course, all of those people generally work with others that are building capacity for others to do research, certainly to encourage research at the bedside and to progress clinical academic careers. So we would certainly encourage people to make use of us, and please do connect with us as well, particularly if you're interested in any of those topics, and perhaps if there's particular interest in any of those areas in particular, decide we could do another series in the future looking at some of those. But we do webinars as well, so any suggestions as to what would be really helpful to groups of people who often do work a bit more isolatedly, perhaps in organisations in this area, we'd be very delighted to hear from you and provide material that is relevant and useful.
If I could just comment, Julie, it's really interesting, isn't it? Because if you mention the word research and you look at the accolades, you know, that you've achieved, there seems to be that sort of anxiety amongst the bedside nurse that how they take what they're doing and they make it into, you know, the work that yourself and your colleagues here are doing. And with a more academic approach to nursing and allied health professional training and careers, you know, undertaking projects to do with academic study and then getting them presented at what people feel, if they've not presented before, in a forum that, you know, there's EACS, there's the American meetings, there's the Society of Cardiothoracic Surgery, all very welcoming and very friendly places for people who've never presented before to realise that writing an abstract and then presenting it and having that feel good, you know, sharing of knowledge and watching the audience come to life and engage like this in questions is really part of that pathway that people have to sort of follow and be convinced about. And then, you know, you don't need to be in a pure academic position, do you? You can do so much of what you're doing on a daily basis and share it that will provide the foundations for, you know, moving this way at the same time as either going into a career in research or even, you know, marrying it, as Susanna said, with the 20-80% and then being able to share that, even if you share at a local level at your hospital. So I suppose one of the things we're doing here is providing a forum to show how that germ can be you know, sort of start off, and the seed can, I should say, sow seed and germinate. And let's not talk about germs, SSIs, etc. But, you know, can move forward into being something that, you know, others are really interested to hear about.
Well, I think you make a really interesting point, and I'm also going to link into the point you made earlier as well, that I'm often asked to give presentations and they say, can you come and talk about research, but can you not make it like too scary? Like, can you make it a bit more like fun or interesting, so that people will turn up and be engaged? And it is just that, it's because we don't have it necessarily as a nice thread throughout our careers, that it makes it that unknown. But I think so many of the advanced practice roles expect a level of research. But actually within our professional codes, no matter really what country you're in, there is usually a strand that says about evidence-based practice and using the best available evidence. And so actually research is about the evidences, and some will be about using the evidence and the research. Some roles will be much more about facilitating research and guiding and making sure that research is going on in their areas, and others will be delivering research and leading teams to deliver the new evidence kind of the future. But the key bit, I think you say, is leadership. So in my role at St Bartholomew's, I have a leadership role to promote research opportunities. So not necessarily just clinical academic careers, but research opportunities. And if you've got that support, you've got that visible leadership, which is all in the literature that says those are the key things to start using research in practice. And then often people will see it as a career opportunity. You can get postdoc posts a lot easier, or then become more part of kind of commonplace within the workforce. And then we start building again the profession. So I think you're right on all of those points. And I think this is where Connect can bring all of those things together, because we all have expertise and are growing our teams and trying to grow it in practice too.
Thank you. That was really important. And I again, just the whole concept that research isn't something that's scary and frightening. You know, the performance improvement projects are something that I've encouraged among our staff for years. And just talking to them about, you are creating evidence-based practice in the work that you're doing. Rosalie, did you want to make a comment?
Yes, I just wanted to make a very quick comment, because I completely agree that many people or many healthcare professionals are scared of research. But then again, as Judy said, it's about having the leadership, and we have to desensitize the staff basically into research as well, and probably desensitizing. I mean, what I mean by desensitizing is making them exposed as well to the whole process of research. So getting them involved even in small survey or a small audit at work, so that they will realize that it's actually contributing to evidence base, as you said, and through that way. So for example, again, we have an experience from St. Bartholomew's Hospital. So so every year we manage to get new people to present to conferences, because they were able to develop their confidence by doing those small things, and then supporting them, you know, talking about the research that they have done. So I think one way of desensitizing to research and making it less scary.
Thank you. I love those suggestions. We are unfortunately running out of time here. So before I wrap things up, I'd like to give Tara an opportunity to make some final comments.
Okay, well, there's no questions and answers or chats, but hopefully the chat between ourselves has covered a lot of the audience thoughts. I suppose I would just like to say, talking of leadership, Jill, Julie, and all of yourselves on the panel, thank you very much for leading what has been a really interesting subject matter that has brought out a lot of the key areas that are really important to our everyday practice. You know, from looking at sort of the sex-based research to what's important to patients, to having them heard, and the wider aspects of infection, etc., and listening to what we call, you know, the patient reported outcomes, and moving those conversations into tangible documents and objective measurements to be able to then move forward. And that's the sort of the link between all that we do, really, isn't it? And how can we augment this amongst ourselves and help and support each other? Because if we support each other, then we will be better at what we do, and that will be better for patients and the healthcare that we provide. So Connect is in its infancy, but moving very swiftly, and feels like it's embedding really nicely. And it's been great to have this opportunity to be able to share the work of colleagues, and you know, looking as we move forward in the future to be able to sort of put some more of these on. So if people have any feedback, we would be very welcome to hear it. So Jill, can I come to you off of mute? And that's lovely, thank you. And then we'll move back to our colleagues at CTSNet.
Thank you so much. I am, when I was first discussing this project with my colleagues at CTSNet, I've been an associate editor there for many years. And this just really inspired me, the work that was being done by Connect. And I really felt it was inspirational for other nurses and allied professionals around the globe. I thank you all for your expertise, for participating at all hours of the day, day and night, above and beyond the call. And really, the CTSNet community and beyond will benefit from today's presentations. I learned a great deal from all of them. And again, what we're all here for today is to better care for our patients. And I feel like every one of these presentations is enabling us to do so. I did mention that CTSNet welcomes content. So these presentations were something that we worked on, but they welcome content on all levels. And so I'll go ahead and turn it over to my colleagues at CTSNet for them to close things out. And thank you all so much for being here and for our audience participation as well. It's been a delightful experience.
Thank you for attending the CTSNet webinar. You can check out Jill and Tara's full guest editor series on connecting patients, clinicians, and outstanding cardiac care through nursing and allied professional research at ctsnet.org, along with hundreds of additional cardiothoracic surgery videos. As a reminder, a recording of today's webinar will be available by Wednesday on ctsnet.org and CTSNet's YouTube channel. To stay up to date with the latest CTSNet content and be an active part of the online global cardiothoracic community, be sure to create or update your CTSNet profile today. If you would like to submit your own video to CTSNet, head to the website to access the submission form. You can learn more about the Connect network and get involved in nursing and allied professional cardiac surgery at their website.